organic mercury is fairly non-toxic. It's used in industrial purposes for a number of different reasons, and because of its toxicity, it's also used to kill things. So it's used as a rodenticide, it's used as for homicide. This was the inheritance powder from the Medici families and others, where that would be used as a way of ensuring that you got your parents' stuff because you killed them, and you were the only one left. So these are just a few uses. Some of these solutions were used. Fowler's solution was used right up and through the 1960s, I think, over about a period of 200 years. The pigment, Paris green, was actually used as a rodenticide in the Paris sewers, but it was also used as a pigment in wallpaper back in the mid-1800s, and would leach out of that, and actually because of the process of both the moisture and the mold growth, as well as heating the area with flames, fire, they would convert that into a gaseous form of arsenic called arsine, which is also used in industry currently, causes a completely different set of symptoms, but all of these are forms of arsenic that were very commonly present in the environment over a period of time. So we have a number of mass poisonings that occurred over the years. Some of these are back in the mid-1800s, but if you look at this adulterated donuts in the 1980s, this was actually an individual who has a fairly extensive history in the medical toxicology area, which is Michael Swango, who's a physician who felt that he really needed to poison people, felt that that was what his skill set should be used for, and killed a number of people. Was convicted of killing 4, but is thought to have killed scores of people in Zimbabwe, as well as a number of people in the U.S. When he was in Illinois waiting for his licensure during a period of time when he'd already been convicted of or sent away from some other facilities where he was thought to have had a role in patient deaths, used arsenic to poison his fellow paramedics, and that's where that issue came up. In Maine, just a few years ago, we were peripherally involved. It's a state near where I practice, where a custodian of a church had poisoned the communal coffee urn in New Sweden, Maine, and killed a couple of individuals, sickened about half a dozen of his fellow churchgoers. This was a very, very small town, and as you might imagine, this fellow who was found criminally responsible committed suicide shortly after being arrested, but tended to implicate in a letter that he wrote some other unnamed individual, and that's completely changed the whole manner of living in this small town, and people are still to this day, uncertain and fearful of their neighbors, and they lock their doors, and they never used to do it, that kind of thing. So arsenic has a long history, and the question is, how would you ever recognize it? And the clinical presentation of arsenic poisoning is very much different whether people are getting a large dose, a small dose repetitively, or even lower dose over a long period of time. So clinical acute arsenic poisoning would be only present from what would be called high-dose arsenic exposure. But high dose, we're talking about a couple hundred milligrams. So this is a fraction of a sugar packet, for example, of arsenic would be enough to cause this spectrum of toxicity. And usually very early onset of very, very bad GI symptoms with very prominent diarrhea and dehydration in that setting. You can end up with other organ systems affected as noted there, but those tend to be fairly significant doses. It's much more common for people to have what's called a subacute arsenic toxicity, and this would be often following a attempt at murder, where people will show up having reported an acute GI illness a couple of weeks earlier, and now complaining of some numbness and tingling, kind of a stocking glove paresthesia, as well as just noting that their hair was falling out, funny looking lines on their nails, although not pathognomonic for arsenic poisoning, can occur with selenium and with thallium and a few other things, but you'll notice these transverse white lines, picture in the next slide coming up, and those tend to be a little bit more delayed. And so people have a GI symptom as a prodrome followed by a neurologic and hair, nail kind of group of symptoms. And if you hear that, that should really raise in your mind the possibility of a heavy metal poisoning. In this case, arsenic or antimony would be suspects, but you will be hearing just shortly about yet another metal where that it can be the presentation as well. And a lot of dermatologic changes that occur with this as well. So here, although it's not a clinical finding, once you start looking at their blood smear, for example, you'll notice that there's some fragmentation of the nucleus within the white cells, which suggests a part of the problem that this element can cause. You also notice these Mies or transverse white lines that are across the nails, and that'll actually be useful to date the period of time of exposure, because the nails grow about a millimeter a week, and so you can kind of date from the time that they clear the perinichial fold when the exposure might have occurred. And this is actually the first patient that I was consulted on, was somebody who was referred out for an oncology evaluation because of the abnormal white blood cells that had been observed, and they thought the person had leukemia. They did a bone marrow evaluation, which was actually normal in terms of any leukemia, but they had these Mies lines present, and they sent off an arsenic measurement in the urine. It came back in the thousands of micrograms per liter, where it normally should be maybe 20 or 50, and we were consulted on that patient. A much more problematic issue for large swaths of the population, though, is chronic arsenic poisoning, and this is a real problem because it causes an increased risk for a lot of chronic health conditions, diabetes, cardiovascular disease, as well as a number of cancers, both lung, liver, bladder, and skin cancers, where these hyperkeratotic pigmentation will progress on towards a squamous cell cancer. And this is an issue that is affecting, more than 40 million people in East India and Bangladesh at this point. Talk about that in just a minute. And I'm not going to get into it here, but the idea is that the trivalent arsenic, which is this arsenic trioxide, for example, form, has an effect on potentially a couple hundred enzymes are inhibited or altered in their function by exposure to arsenic. Pentavalent arsenic, which is what's commonly present in foods that are grown in soil that has a heavy arsenic contamination, will not be as toxic, but in the body it can be converted to trivalent arsenic and therefore presents a potential risk for further toxicity. I mentioned that the issue is most prominent here in this area of the world, and perhaps Ashish could even mention a little about this a little bit later. But this is a real concern with millions of people who are exposed in what was initially a public health attempt to decrease acute disease by the drilling of tube wells that go down deep, sample from the aquifers. The aquifers unfortunately contaminated with arsenic as they leached out of the normal and natural occurring ores there. But in trying to avoid a parasitic disease, now millions of people are confronted with this issue relating to arsenic. And I'm not sure you can read it up here, but this map shows you the likelihood of having an arsenic level above, and the units translate to 50 micrograms per liter. And as you can see, most of those areas are actually likely to have a greater than 50 micrograms per liter. And that contrasts with the United States current level for EPA for drinking water, which is 10 micrograms per liter. So, several fold higher than that. And the highest concentrations are actually up in the 2,000 micrograms per liter, a couple as high as, say, 3,000. So these are very, very large concentrations of arsenic. It isn't only in that area of the world, though. This is a picture of the northeast United States. Actually, I live right there. And this is the state of Maine. And large areas of the water sources off of the mountains in these areas have also what is considered high, by U.S. standards, arsenic levels. But again, these are now 5 microgram per liter, so completely different scale than what we're used to. But we do see arsenic poisoning in the United States, and this is a woman who one of my fellows saw when he was practicing up in Maine, who had noticed that she was getting more and more freckled, as she thought it was, although it was an itchy rash that she was having on her legs and the soles as well. And she was complaining of increasing numbness. This was increasing over a period of about 10 years. And it was attributed to the fact that they were using a private well, which is not regulated in our country. You're responsible for your own water condition there if you have a private well. And they didn't really stumble on this as a concern until a neighbor dug a well and had it tested and found that it had 2,500 micrograms per liter of arsenic, and this is the same water that the neighbors had been drinking for 17 years. So they needed to get a new water system in place. So real arsenic poisoning, this is what's being experienced in Bangladesh and East Bengal. If you think about it, people are consuming large quantities of water with very contaminated sources, and they are ending up with this chronic health issues. In the United States, and this is kind of to focus on the public health aspect of this, when we went from 50 parts per billion to 10 parts per billion, suddenly a whole large numbers of water systems were out of compliance. And this is one, Exeter, New Hampshire, which on that map is just a little bit west of where I was showing you. They found some measurements that were 11. 11's higher than 10. It was less than 50. It wasn't a problem. And suddenly now they're in violation, and these whole communities have to put in very expensive systems to try and filter the water. It's gone on further, and from our point of view, they're maybe going a little too far. This is copper chromate arsenic treated wood, which is a preservative, is used in a large number of building issues for playscapes and decks, put outside the back of your house, that kind of thing. And now the concern is that this is going to leach into the soil, or people might get exposed if the kids are playing on the playscape for too long. Large number of studies coming out about the degree of contamination that that's causing. And what it basically led to was the EPA saying that no more can you use CCA-treated wood, and everybody should take apart and demolish everything that they've used. Don't burn it, because actually that is a good way of getting very exposed. But the data that they were using for that was along the lines of if you were 3 years old all your life, and ate a sandwich on the deck every day of your life, and then had a lot of hand-to-mouth behavior, you might get too much arsenic to be safe. Now, first off, you can't be 3 your whole life, and even if you were, you might vary your diet from a sandwich, and you don't have to eat on your deck every day. But that's the kind of thought process that went into some of our safety regulations. So there's a lot of data that we're not going to take time to go through here, but be happy to point you to some of those. Some of the epidemiology studies that started talking about the risk for a lot of chronic health effects that drove now our safe level were based on statistically significant changes, but they were using the population in Bangladesh, where the concentrations of arsenic in the water were orders of magnitude above most of what we were having to deal with in the United States anyways, and also above where their safe levels are now. And then there were some bad studies that are out there, which is always something I want you to remember to pay attention to when you're trying to look at the literature. This was just a study where they took people who had diabetes and then measured arsenic in their urine, and there was an association with diabetes. But if you think about it, if you have diabetes and you're not in great control, you're having an osmotic diuresis, and therefore you're drinking more water. So if you have arsenic in your water and you drink more water, you're going to have higher arsenic levels. So it's reverse causation. The arsenic comes because you have diabetes, not causing your diabetes.
Last 10 seconds.
So laboratory diagnosis, we use urine as the method. Nails and hair can be done if you're doing a forensic investigation for potential criminal activity. Treatment is really supportive care, getting people out of the situation where they're continuing to be exposed. And if you have acute toxicity, as Paul was mentioning, for mercury, for elemental mercury, we do have chelators that will work. DMPS has been used and was used in that main case. Succimer or DMSA is our ready go-to, and BAL, or British anti-leucite, is the older agent. And I'll just leave you with this, these are just some things to keep in mind when you're going through the literature. Be careful about people who extrapolate from cell culture data to humans without really taking care with the steps in between. We have to be careful when we're using regulatory language because, and this could go either way, if you say, well, it's safe for somebody working in that environment, but now you're applying it to an infant who's in that environment 24 hours a day, kind of like the difference between the mercury levels of home versus school. You want to be careful you don't misapply a regulatory framework to an individual exposure. And you can't extrapolate from low-level to high-level exposure just because you're ignoring a lot of reparative mechanisms as well as differences between experimental animals and humans. This has continued to be an issue. We have TV people who provide advice that people like to follow. I don't know if you catch our shows or if you have a similar issue here, but one of our guys is Dr. Oz, who's out there. And now, although he was a cardiac surgeon, he now is a toxicologist and a laboratorian. This talks about him running tests on apple juice, looking at contamination with arsenic. And actually, he's never been in a lab, so it was other people that ran the tests. But the things you need to remember is, is this a setting that's got any similarity to the concern? So they were applying the levels found in juice to water consumption, and we never could suggest that people drink a liter or two of juice a day. Water is got multiple safety factors on its regulatory limit, and it's inorganic arsenic, not organic arsenic. So I mentioned the organic arsenic issue, and those are things to keep in mind, because if you take somebody and you measure their urine and they have been eating seafood or shellfish, they will have high arsenic measurements, but it's almost all organic arsenic, which is non-toxic. So you have to speciate the arsenic, which is a completely different test. It means running it through a liquid chromatograph and an ICP-MS, which is a difficult set of tests to perform. So I want you to just take away that it is possible. If you have a private well, it should always be checked for a number of different substances. If you have a very high measurement, then it should be mediated or remediated. If it's just above a regulatory limit slightly, probably doesn't mean anything for your individual health. There's a lot of different sources of exposure to arsenic, including smoking. And try to not take all the media reports as verbatim. And I'll leave it with that. Thank you.
Thank you. Chuck, you took 3 minutes extra, but then it was very interesting to listen to you. Since we are running short of time, so I won't allow any questions for this talk, because I want to listen to the next speaker, who is Dr. Abdul Qadir. He's professor and head of emergency medicine at Canlı Technical University, and he's an expert on mad honey poisoning. So who best to talk to you about mad honey than the expert himself?
Well, I'm not sure what I am doing in the poison control track, but I think it's related to public health somehow. And you must be wondering what is my topic is about. So let's start. So my name is Dr. Saad Labri. I'm actually a clinical toxicologist and an emergency physician consultant at Sultan Qaboos University Hospital in Oman. And I hope you know where my country is. It's nearby you. It is beautiful country. So what I'm going to be talking about, you must be wondering, is it going to be about your cup of coffee that you take in the morning? Extra cup of coffee, extra caffeine? No, I'm not going to be talking about that. So I'm going to start with 2 cases which actually I had during my clinical practice, and as a toxicologist, I was involved somehow. So the first case is a 27-year-old man who was previously well, healthy, was brought in cardiac arrest, and the only positive history, he's working in a gym, and he started using supplements just 6 months back. The second case is a 29-year-old male who is a bodybuilder, came with a shortness of breath. He had been diagnosed recently to have cardiomyopathy with ejection fraction of around 20%, and he was on anti-failure medication. And he was not looking well, basically. So what is common factors between the two cases? So they were both young. They are previously healthy. They are taking some sort of supplements. And one more thing, apart from the fact both of them had very bad outcome, they were looking like this. Actually very huge and muscular. So the outline of my talk is going to be about what is actually performance-enhancing drugs, what is the epidemiology all over, and what is the common misperception about them, what is the reported cardiotoxicity, and at the end, summary. And I think the right side of the screen can tell you about the whole topic. So actually, the performance-enhancing are pharmacologically produced agents. They are not supplements. They are not nutrient. They are not natural by any way, despite what the manufacturers and the company says. And the common use for them are by athletes and non-athletes, were weightlifters, to enhance a performance. And that's even a misperception. Why then we should be concerned if it is an athletes or sport-related thing? Unfortunately, it's not. Well, to start with, it started with athletes, but because of the common belief, they can actually give an enhanced performance in terms of gaining more muscles, becoming more strong in weightlifting. People start using them in the public, specifically the young age group. And there have been a lot of fight initially by the ethicists, like, why not? Isn't it like we are supposed to go for physical excellence, and the more good we look, it's actually the better? But unfortunately, it's not true. So actually in US, at least 3 million performance-enhancing drug users alone, and this is just based on one studies, and it ranks on top of type 1 diabetes and HIV infection prevalence, which is really serious, which make it #1 health threat. Specifically, across all the studies that reported it, it's a very common thing in young age group. It's between 22 to 24. So the young generation are the most commonly using these drugs. And I actually have abstracts in this conference about just a pilot study that we did in the country, and it was randomly selected 120 gym only in the capital itself. It's not even all the country, which is I'm planning to do next. And the age group, almost 64% were also young age group, 80 to 40, 75% of these people are actually using supplement. And they are gym members, and again, reminding you, they're not athletes. They are actually regular people who are going to the gym. And unfortunately, 53%, they don't even know any side effects. So lack of awareness completely about side effects, and they don't even have a proper trainer or proper medical checkup, which was really shocking. So what is the misperception then? Why the young age group go for these supplements? They don't know what they are. They're just using them. Actually, it's because of the media influence. So a lot of them, they just get the peer effect, the pressure effect. Okay, I want to look better. I want to have more muscular, and what is actually the best and fast way of doing it. And unfortunately, the media is not helping, because previously the attention used to be regarding the athletes that use it just to gain competitions, and then a lot of illegal action have been done for these sport people, but then no real educations or awareness or even banning or bringing to the attention about the health risks. So most of what happened is, okay, so this sport competitor was actually rewarded because he was using illegal supplements, but nothing really beyond that. So public attention is not there. And the vast majority now, it's not athletes, are actually the normal public. They are the normal people who are going to the gym. And it is greatly underperceived. And it's not even performance enhancing anymore. Actually, now the terminology itself is changing. It's either a body image enhancing drugs or appearance enhancing drugs. They are not performance. Actually, most of the people that use them now, they are not behind performance. They are more behind looking more muscular and lean. And then there are lots of kind of reports coming out of a very famous bodybuilders who are having actually stunning, shocking death at the young age group. And despite that, still the problem continue. And this is one of the very common famous case that went to the court in US that have DMAA, which is diethylamylene, which is one of the stimulants, and unfortunately the disease was a soldier man who ended up having lawsuits by his family against the GNC websites, which is actually was really kind of advertising this product very heavily as an ultra-intense muscle gorging strength, energy power, and endurance. And now it became a banned product after a lot of deaths, including acute MI and sudden cardiac arrest. But it used to be really publicly used by the bodybuilders. So what are the cardiovascular effects that have been reported with these performance enhancers? So cardiomyopathy, myocardial infarction, you just name it, cardiovascular accidents, conduction abnormality, coagulation abnormality, and then each one of these compounds have its own kind of risk factors, because when we say body enhanced drugs or these supplements come in different shape and format and compositions. They are not only one type. If you can see, there are multiple. So you have oxygen carrying modulators that have erythropoietin, and then you have the anabolic agents. You have also adrenergic receptors antagonists, and you have also the receptor modulator. So it comes in multiple things, and the cardiovascular risks that are reported here are mainly the direct cardiovascular risk. There are also other indirect cardiovascular risks. And if you can see, the majority of these reports come from the anabolic agents or androgenous anabolic steroids. So we'll move on to the anabolic steroids, since they are the commonly reported cardiotoxicity literature actually come from those agents. And the mortality among athletes using these supplements is almost 6 to 20 folds more than the clean athletes. This is only athletes report. And 1/3, as I mentioned before, one third of these deaths are actually related to cardiovascular. So what is the direct? As you see in the previous slides, it's either dyslipidemia, so they can have decreased HDL, increased LDL, and then this is more pronounced if they are having oral intake of these anabolic steroids. You know that they come in injectable format, and unfortunately in my study, it was very hard for us to get this information out because injectable anabolic steroids are illegal there. So it's kind of going to be very hard to convince people to disclose this information for even a study purpose. But I know it exists, and I know people actually getting it illegally from other sources. And the other sad part of the story, actually, performance-enhancing drugs, and this also reported in the literature, it's the door to start using even other illicit drugs. So usually it starts with supplements, and then they move on to any other kind of drugs. And in my country, I actually noticed this in my clinical practice, like most of the drug abusers actually are commonly going to the gym and getting their drugs even from the gym. I'm not saying you guys don't go to the gym, but it's a common factor. So what is the evidence also existing for their cardiovascular toxicity? You have also postmortem. Most of the evidence existing are by case report and case series. As everything in toxicology, it's very hard to have ethically approved study to compare the effect between these supplements. But then postmortem and experimental, there are actually recent conduction studies that showed decreased cardiac electrical stability, autonomic cardiac regulation is also affected. You have abnormal ventricular reboalization, and as a result, you definitely have more risk of arrhythmia. And this specific finding was also tested in rats, and it was proven to be also correct. There was also other study looking at 87 diseased men and which were tested positive for anabolic steroids. And what they found, they had great cardiac mass comparing to other kind of men if they adjusted all other factors. And also there is ventricular hypertrophy, fibrosis, and myocyte lysis in cardiac death in anabolic steroids. What about radiological studies? So this is in living people who are actually using anabolic steroids compared to those non-users. There is definitely decreased ventricular ejection fractions, reduced diastolic tissue velocities, and one study is demonstrated specifically decreased aortic elasticity, and I'm going to discuss this later on. Again, there is also coronary artery calcium scores higher based on the radiological studies compared to men at a comparable age, which again put them at risk of atherosclerosis and MIs compared to normal populations. What about human growth factors? Isn't it that if you grow better, bigger, it's going to be better? I don't think so. So it's actually little known specifically about the cardiovascular effects, but if you see the acromegaly patients who have actually excess, like if you just extrapolate the results of acromegaly patients, they have hypertension, congestive cardiac failure, and cardiomyopathy. So you can guess if they have excess growth hormone, definitely risk of cardiovascular is there. Beta-alanine supplements is one of the commonly used now between athletes and non-athletes due to the illegality of anabolic steroids. Actually, it's found in 60% of sport codes because now it's self-reported because it's actually not a ban product. And what do we know about the supplement itself? Is it really toxic? Studies of adverse effects itself is not really there because we need time in order to see the long-term health effects with these supplements, but neurotoxicity, respiratory distress, myotonia is all seen in humans who have excess beta-alanine in metabolic cases specifically. So again, if you extrapolate the results, you could expect some effect to be there. And this is also one study done in Tour de France cyclist events, which is a common cyclist event done. Actually, the first cardiac death happened in this event. It was back in the 1960s, but this study specifically checked between 2 years, like 1995, the blue one, and then 1999, and they were checking their ejection fraction and cardiac mass by echo, and they noted that their heart is becoming bigger as the year go, and they're actually their function or ejection fraction is becoming less. And at this specific year, the use of performance-enhancing supplement was becoming very popular. So that's one thing to be put in mind. Animal studies also have demonstrated some bad effects of clenbuterol. So there was increased atrial and ventricular size and increased aortic root again, and kind of decrease in the elasticity, and they notice actually sudden death in horses. So this is experimental study done in horses, and the poor horses end up dying from aortic rupture. There are other modulators or androgen receptor modulator, and the reason why these substances came in because androgen steroids were becoming illegal, so they were trying to bypass detection, so they brought these receptor modulator. Common example is thiomycin beta-4, and they dissociate the androgen and anabolic effects, making them undetectable. Still, very little is known about their cardiovascular risk, but if you just think about it, if they are going to be acting on the same receptors, probably effect is going to be there. We just need to wait and see the effect. And the end results for some of these people, so if they did not die, some of them, they may end up having really very bad cardiomyopathy. And the example is the patient I saw. He was huge, young, but cannot even walk without assistance. He will probably need eventually a heart transplant. His heart is big and not working well. And some of these people walk around with their external ventricular device, assessing them in their daily lives. So in summary, it's actually a very common use in young, and this is even in my country, leave alone other countries, and even in US it have been reported. There are many types, and unfortunately the young generation, they don't even know what they are using. They just want the quickest way to look fit, big, and lean, regardless of what will happen next, and this is really striking and frightening. and there is no awareness of adverse effect, and there is no even increase kind of public educations regarding this, because it's having lots of opposite action from the companies who are making them. Actually, what I came to know, that trainers in the gym, they get some sort of commission and advantage the more they sell these products. So it's a kind of a revenue and big business. So it's going to be hard to actually oppose business. And lack of regulation and proper control. A lot of these are regulated in the sport activity scenes, but in public there is no proper actually control. People can access whatever they want, and there is no shop, no place now where they don't have the supplements displayed there without a proper warning. And definitely cardiac toxicity does exist, including sudden death or long-term cardiac diseases. That's all about my presentation. These are my list of references, and keep calm and call toxicologists. Thank you.
Thank you.
Questions?
We have time for 2 questions, I think.
Any questions? Yes.
Please.
Yes. That's striking?
Maybe not. Supplements, is it like multivitamins? Is it on?
So supplements, no, so supplements, what we specifically meant, supplements in the gym. So it's not, they were not talking about vitamins. And even majority of them, they don't even know. They are just buying supplements to enhance their performance and gaining more muscles, but they have no idea what supplements they use. Some of them, they were actually not kind of keen to give us the information because they were afraid that some illegal actions will be taken about. But I knew, like from my own sources in the gym, they are injectable, like some of these supplements come injectable, and most probably they are steroids. Yeah.
Is it the time now that there should be some regulations for any gym to be open?
Absolutely.
To have a specific recommendation
Absolutely.
to be assigned to a physician, a doctor, and maybe not to leave it like this.
Absolutely, and this is what I'm trying to do, because the first thing, you need to prove that problem exists, and you have to submit the data. So what I did only a pilot study in Muscat. Now I'm planning to extend my study to include all the country and just to screen what's going on there. And I'm trying to get more information to actually submit it. Huh? Oh, great. And the thing is, the problem is, what I noticed, lots of opposition from the gym themselves to participate in the studies, because again, it's a money-making revenue for them. Like the more they provide supplements, the more they get money, and they try to convince people who are there to actually, and you know what's striking, which I did not mention, many of these actually users are undergrad. They're too young even to be knowledgeable to know or decide. They're undergrad. They're not even like, they just either finished their secondary school, they're just in college, so they don't even have the full potential to understand the consequences. They just want to look good, no matter how they will end up.
I have one question. In your country, is it easy to buy on internet, or there is?
Yeah, this is another thing which in US probably it's very easy to get things through the internet.
Yeah.
Well, we don't need to bring it through the internet.
Exactly.
A lot of people smuggle things through the borders, and it can get access easily.
Okay.
So they don't need to order it through the internet, so they can get it delivered to them in the gym. And as a toxicologist, I'm telling you, most of what I see as overdoses cases, when I ask them where are the sources you get your drugs, it's the gym. Like they have a connection, they can get things easily.
It's the same in Italy.
Yeah.
Okay, thank you.
It's easy. There are a lot of shopping centers.
Yeah. Vitamin shop called.
Like there are so many gym there, but probably only 2 are certified for selling specific products. The rest are just on their own, unfortunately. Yes.
Please.
So I'm curious, with these drug users, are they doing injections?
Yeah,
IV
this is
injections?
what I tried to get. So even when we went to the questions, is it orally or injectable? Nobody want to answer the injectable ones, because the moment you say injectable, it's actually most probably anabolic steroids. So I had hard time getting any of these answers, but they were answering we were taking supplements. So I have to go again and review my data with the members who were with me, and then actually when they question, without them, they said, we are not gonna write, we are taking injections, because they are so scared to actually declare this information.
So my question for injection drug users, does Oman have resources for harm reduction to prevent transmission of diseases? And
Actually, illegal, so injectable supplements are illegal in the country. They are not supposed to come there. But again, we are talking about getting it in an illegal way, and still they are using it the way they use IV drug. It's illegal. I mean, IV drug abuser, they use IV, right? It's illegal, but still people can get access to.
Sure,
So you are talking about infection risk the same way that it's existing. But how to monitor it, how to report it, that's the challenge.
Understood, but are there practices in Oman to provide people clean needles and teach them how to prevent?
Oh, no, they are so meticulous now about actually getting their own needles for injections. So risk of infection probably is less. So they get a one-time loaded syringe, I guess.
Thank you.
Thank you.
So thank you. I think we can
Okay.
go to the coffee break.
Okay, thank you.
Thank you. Thank you all the speakers.
Audience to join us. So we're going to start this afternoon session on clinical research in emergency medicine. Our first speaker is a regular Menatox presenter and well-loved. Dr. Lisa Marina Walton is a professor of EM at Louisiana State University, president of the American Academy of Emergency Medicine. Besides having an MD, she also has a master's in clinical research. Lisa has numerous research grants, over 350 national and international research presentations, and now she's going to speak to us about emergency medicine research.
Thank you. Okay, I don't have a microphone, but I don't think you'll have trouble hearing me. It's kind of a small room, and I've got a big mouth from the South Bronx. So I'm going to talk to you a little bit about how to conduct research in the emergency department with somewhat of a focus on toxicology. The clicker is not working. Can you plug it in? Give me something that works. This doesn't work. Okay, good. All right, so we're going to talk about what research is. So I like to use the NIH definition of research. It is a systematic investigation designed to develop or contribute to generalizable knowledge. So there's a little bit of a problem sometimes with generalizable knowledge, as we saw with the panel discussion last time. Generalizable, it doesn't always work, especially in toxicology, right? Snakes are not the same in every country. I think they can hear me, thanks. Envenomations are different. Poisons are different. You see a lot of organophosphate poisoning in Eastern countries. You don't see it as much in the US and Canada. So generalizable knowledge can be a problem, but certainly doing a systematic investigation that is well designed and develops knowledge is critically important. So how does good research start? Good research, I always like to say, starts with a good doctor. So you're a good doctor, you're in the emergency department, you're doing your toxicology consults, and you start to think about why do we do things the way we do them, why do diagnoses present with certain symptoms, what resources do we need to give better patient care, especially important in toxicology with antidotes and antivenoms, and can teaching be enhanced? I notice that patients do better when I do X. So all of these things can help you to develop your research question, and then you have to pass certain tests, right? Now there are a whole lot of tests that people use to say, is this going to be a publishable project? Is this going to be something that I can do? And I'm going to go through these one by one. These are the ones that I use. So who cares? So a common question is, you may be passionate about something, but other people might not. But everybody is passionate about teaching. But there is a certain problem that I see all of the time with junior investigators, and that is people who are teaching sort of a teaching tool that they use and that's very effective, and then they want to publish it. So they say, well, we're going to find out whether people know more after they use my curriculum and whether they're more comfortable doing this procedure or engaging in this particular patients with this particular diagnosis. So I'm going to steal a quote from Michelle Byros, and Professor Byros was the editor of Academic Emergency Medicine for a number of years, and she said, look, medical students and residents are intelligent people. If you teach them something, they'll learn. And if you let somebody do something, they're going to be more comfortable with it. So this is not the kind of a thing that anybody cares about. This is an example of something that somebody's going to say, we know the conclusion before you did the study. So what else can you do? What can you do instead? There are plenty of venues, online and otherwise, in which you can actually publish in a teaching journal your curriculum. And then what are the kinds of things that people do care about? Can you put a certain twist on it? For example, instead of using faculty, can you have senior residents teaching juniors or residents teaching medical students? Do you use simulation in a way that's never been used before, such as disaster? Instead of doing a tabletop exercise, can you do a simulation exercise? Think about what's important in learning. Right now, we're focusing on retention. There's been a lot of studies in resuscitation that shows that we teach people how to do CPR and they don't know how to do it properly. And 3 months later, even, they've forgotten about the rate of compressions or the depth of compressions. So does your method have something that makes it more retainable? So 3 months you can follow up, 6 months you can follow up. And some of this can be done with toxicology as well, because a lot of toxicology patients require resuscitation. So you can think about doing some of those teaching studies. Ethical. Studies have to be ethical. So to me, one of the most impactful studies, and it's because I do a lot of work in diversity and cultural competency, and so I actually love this study, but it's one of the most unethical studies that ever was performed, not in a horrible way like Tuskegee, but in a way that, clearly involved lying. So this study, Jacobson and Rosenthal were two social psychologists, and they wanted to see what the impact of what was not then called implicit bias, but is implicit bias, actually was. And so people took the Stanford Binet Intelligence Test in the United States, and they took the boy and the girl in each class who were the most average students in existence. And they went and they told the teacher, these kids in your class are absolutely phenomenally brilliant. There's nobody smarter than them. They are going to be the gems of your teaching career. They are just going to shine. And by the end of the year, the school year, what happened was those children who were boring average kids with average intelligence got straight A's, were reading 4 years above their reading level, were performing on math tests a minimum of 4 years above, and why?